Hello, welcome to day 4. Thank you so much for your patience. Yesterday we were not able to have a class, but today I have quite some time off, so I'm still debating on whether I should do day 5 today and just send it to you as a recording. Okay, we'll see how it goes, but welcome again to day 4. Let me make sure I'm not too hidden. I hope you're all doing well. Yeah, I have a nice saying today: true gratitude is losing everything and still finding a reason to smile. If you're alive, all is never lost. Think about it. If you're the last person standing, you might be the winner. Okay, so let me move us all the way down here, and then we shall start today's session. Happy Saturday. Now, high-risk injuries. You will find high-risk injuries at work. People get hurt all the time. And because you are the doctor, and of course you are in a position of leadership, okay, and we also teach this to our medical students, people will come to you for solutions. So it's important to always try and prepare for your day. You're thinking, if this goes wrong, we're in surgery. If this goes wrong, what can I do? If this goes wrong, what do I do? So you're never just surprised. And this is how you can gather information, okay, by making predictions. Yeah, not everything runs smoothly in the hospital. People get hurt. In fact, it was quite insensitive. When was this? I think last month. One of our junior doctors was accidentally electrocuted during CPR. Why? The one who was managing the defibrillation said all clear, but did not look at the bed and say all clear, wave his hand across the bed, making sure that the oxygen, if it's not in a closed circuit. So if you're bag and masking a patient and you're about to give the patient a shock, it is important for you to put it at least a meter away from the head of the bed. Come on. If it's a closed circuit, of course, you can still give the shock. But one of the biggest things when you're doing defibrillation is the safety of those you're working with. So unfortunately, we had an injury where he said all clear. He just quickly glanced. Of course, there are many people in the room, yeah? And the poor doctor was shocked. Boom, hit the ground. Now you're dealing with 2 patients, okay? Of course, incident reports. Of course, your first priority is making sure that the person is okay. So if you are on the other side of, of the valley, let me just use nature. If an accident has happened and you are not there to observe it, you must get details so that you can get a good picture of what happened exactly, all right? Now, I think I hear a little bit of ruffling. Maybe I did not mute all of you. So let me just mute you, help you, okay? But that's the thing, expect injuries at work. So, for example, James Smith, the medical student, was assisting in general surgery. I don't know how many students have gotten injuries in surgery. It's honestly something that now we are investigating and sending them for like a high risk surgery training session. Dr. Lian for 30 minutes. You can't come in there and just all you're doing is just looking at the pictures of endoscopy. I'm just looking to see what's going on in the surgery. You don't know where your hands are. Boom, somebody sticks you. Okay, so these things are expected, and it's important for you to know how to deal with them. Let's talk to James, medical student, was assisting in general surgery. Poor guy, when the consultant accidentally stuck him with a needle. You're the FY2 in the emergency department. Okay, so could he be stuck with, could he maybe handle sharps? Maybe it's the surgical technician who was handling sharps after surgery, and the patient had HIV, and she cut herself with the 10 blade. It could be that case. It could be a case where a patient is being given IM, injections in an aggressive patient in psychiatry. Okay, he's been given IM Haldol. He hit the nurse and stabbed her with the same needle. Okay, it could be just a simple procedure where a nurse is about to give an injection and sticks herself. Have I done that before? Yes. I've drawn up insulin and boom, I don't know how I ended up sticking it to myself. Is that a big deal? I just took the needle and I dumped it, and I had a little bit of orange juice and crackers afterwards. Of course, I talked to my department about it because it's important to report these things. Yeah. Now, another nurse can stick herself. She's coming to the emergency room, or this one has been sent to you and you're working in the emergency room. What is the first thing you do? It's a colleague. Compassion. Hello, James. My name is Dr. X. I'm working in the emergency department today as the FY2. I'm very sorry. I just read from the notes that you've injured yourself. Before we can continue, I need a little bit more information. What's your full name and your age? No problem. You can do it that way, or you can go in, hello, my name is Dr. X. Are you James? Can you confirm blah, blah, blah? Don't go in and say, what's your name? How can I help you? Why did they give you the question? Why did they give you the information? So don't go there and say, how can I help you? Just put on my charger. My screen may go dark for a few seconds, but it'll come right back. Okay, so I saw from my note that you have had an injury. Can you please tell me about it? Oh, doctor, I really was just helping with retraction in a surgery. I don't know what happened. The consultant just stuck me with a needle. I am very sorry. Where did he stick you? Okay, he stuck me on my right hand, and I'd like to take a look at the area. What did you do? Did you wash the area at all? Because this is more important than finding out what's your medical condition. Do you have any allergies? Do you have any family history? Did you drink ginseng tea? Do you run around and eat chips, fish, and burgers? That's why people fail in consultations. It's because they are not systematic. He has come with the injury. I want you to find out, where did you get stuck? Okay, what did you do? Are you in pain now? I'm in a little bit of discomfort. Do you want me to give you something? Even a little bit of paracetamol. Break a 500 milligram tablet and give him. He's no longer a doctor, he's a patient now. He's no longer a professional, he's a patient now. Okay, so find out, when did this happen? What is the location? Okay, well, you can skip duration, but you may want to say earlier on, I'd like to check on the wound just to make sure it's not bleeding. If it's bleeding or if it's a full laceration, guys, you have to at least do some first aid. Put some pressure on it. But what were the events surrounding? We were doing a hernia repair. The doctor stuck me with a needle, and now I am here. All right, before this, did you clean the wound? Are you in pain? All these things you have to take care of. Now, sometimes they may say, I cleaned the wound. You want to find out how. Okay, did you just rinse it underwater? Okay, and that's the thing. A percutaneous exposure and a mucocutaneous exposure, a little bit different. What if it was blood that splashed into his eyes? What was he doing in surgery without goggles? The risk of hepatitis is so high. Come on. I see some of my colleagues scrubbing in and they don't have any goggles. They're like, oh, it missed. I'm like, you get these things, you know. There's no cure for hepatitis C. Well, there is a cure, but it's quite expensive. Is it Harvoni? Yeah, they give her warning. Anyways, hepatitis B, I'm sorry. Yeah. Now, mucocutaneous exposure. So depending on what happened, then you offer the treatment. But if it's a cut or a needle stick, at least you should have squeezed it. Squeeze around the wound and wash with soap and water. Okay, just rinse it out. He has to try and squeeze it. Okay, now after that, then you want to say, it's good that you're here. I need to find out the time that this incident happened and the time you reported it. Why? Because we need to start certain things in a time frame. Okay, so this is why I use old cut for everything. And for those of you who do not know what old cut is, it's just a system of gathering data: the onset, location, duration, characteristics, aggravating symptoms, alleviating symptoms. What is the other one? Aggravating, alleviating, associated symptoms. Okay. Is it radiating anywhere? So you can use it even for pain. Is the pain radiating from X to Y? Look at the other videos and you'll understand a little bit more how to use old cut. And the T, is this the first time you're seeking treatment? Okay, but follow a nice systematic approach because you understand this guy is scared or the nurse is scared. Okay, it's a traumatic experience to be stuck with a needle. There are so many things, and the biggest concern for these patients is HIV. But don't assume it. You want to ask. Okay, what are your concerns? Even as I try to develop a plan of care for you, I'm just worried I might get HIV. Yes, this is a concern. Never tell anybody don't worry. Let them worry about their problems. Okay, when a doctor tells a patient don't worry, it shows that you're not taking them seriously. Like, this is no big deal. It's a big deal for a patient to present with any condition at all. So don't use don't worry. Okay, now you want to get into the history of maybe his medical history, because you have to deal with two different types of patients: the one who was on the surgical table and the one who is in front of you with the injury. Okay, who do you start with first? The doctor, the one who got hurt. So don't start asking about the other guy on the table. Consultation. So you're moving from inwards going outwards. James, do you have any medical conditions at all that I could be concerned about? Diabetes? Could you have high blood pressure? Any problems with your immunity at all? No. Have you had your vaccinations to prevent you against any diseases? What was the recent vaccination that you had? Have you had your hepatitis series? Okay, when was the last time you had a booster shot? Okay, now the thing is, when you go to get a job in the NHS, you have to be cleared by occupational health. So this doctor should at least have had his hepatitis series. Ask, find out. Okay, why? Because sometimes we may need to do titers or just give him the Hep B booster. Okay, now after you found out about his medical conditions, how far would I go? Would I go into, have you traveled recently? No, I wouldn't go there. I would not ask him his occupation because I know that he's a medical student. Okay, so even when I give this question in a mock, people waste so much time in gathering non-essential data. Why do I need to know his diet? Why do I need to know if he's a smoker in this instant? These questions are important, but not in this instant. Okay, does he diet? Does he exercise? If he doesn't, why don't you exercise? You're moving from the focus of the case and you will not finish the assigned task. So medical conditions, allergies, family history, then I'd go right back. How many times have you stuck yourself with a needle? How many times have you had any injuries at work? Okay, because if he's a nurse who is sticking himself every week, then there's a problem. He may need to go for training. But if it's a nurse who's just stuck herself the first time, why are you sending her for training? Is it her fault? You know, so some of the management that people are reading, you have to know how to apply it. Okay, we can get knowledge, but wisdom is in the application of that knowledge in a specific niche. Okay, so not everybody needs to go for training. And even saying you need to go for training when somebody presents after an injury is insensitive. Okay. Oh, you should have, worn some gloves. Oh, you should have, handled the needles properly. Mm-mm. Compassion first. Then you get into the site. Where did he get hurt? Can I take a look at it? Can I briefly look at it? Is it bleeding now? Do you need first aid? Do you need some medications, pain medicine? Okay. Then medical history, allergies, family, any family histories at all. I am asking these questions to know whether you are at risk, okay, or whether sometimes some associated conditions can put you at a higher risk and maybe need management that is more rapid. You need to know, okay. Next, can I ask you a little bit of information about the patient? What was the patient's name? And even at this time, do you need to ask the examiner, can I have a pen and a paper? If there's a pen and a paper in the room, find it, get it. Let me just get a bit of details about the patient. What was his name? Peter Wallace. How old? 68. I'm just getting this information so I can follow up. We may need to look into his past medical history and see if he has any risk factors that could affect you. Do you know anything about the patient? No. Okay. Did you maybe go through his medical record? No, I didn't. Now you've gathered information that you can manage in the end. Because in the end, after you've told him that he may need all these blood tests, he has to have safe sex and not donating blood, antiretrovirals, after you have taken care of him, then you can educate him. And you can tell him, it's important. Before you step into surgery, before you do any invasive procedure on a patient, like drawing blood, just flip to their past medical history on their chart, okay? And just check if they have any blood-borne pathogens so that you can be extra cautious. It's important, yes, to put on gloves. It's important to dispose of these, used instruments appropriately, but it's most important for you never to walk into a surgery and assist and you have no idea about what this patient has. Okay, please, that's now education for later. And that's why I say you cannot manage what you have not gathered. And when people come to me and they say, please, can you assist me to prepare for this exam? I've done it almost 3 times. I'm just about to do it for my 4th time. I'm like, one of the important things is to go through your scorecard and check and think, where could I have gone wrong in this case? What did I miss? Go back to textbooks. Okay, talk to your consultants in your workplace. See if there are any deficits. Train hard with other people. Challenge yourself so that you can make those deficits into strengths. Okay. Anyways, so now James doesn't know anything about the patient, but now you've gathered details about the name and the age of the patient, and you at least know the type of surgery, who was operating, so that you can follow up. And you want to tell James, it's important for me to go and work with the occupational health department so that we can investigate a little bit further on the risk factors of the patient. For example, their hepatitis C, B, and HIV status. Okay, we can talk to them and ask them if we can take some blood samples. Yeah, we can find out if they've had any risk factors like drug abuse or tattoos, I wouldn't say unprotected sex, but any high risk factors that would put them at risk of a blood-borne pathogen that can be transmitted to you. James, I'm really sorry. I'm talking a lot, but do you have any concerns right now? Do you have any questions? How are you feeling about this whole thing? I feel guilty. I can't believe that I stuck myself with a needle. I feel so enraged about that consultant. He was just joking and laughing around and he just stuck me. He never even apologized. And then how would you want to manage that? You want to say, I'm sorry, you need to maybe also sit down and talk to the consultant. With any injury at work, of course, an incident report has to be written, okay? And we need to make sure that this doesn't happen in the future. So we can talk to the consultant about this. And I'm sorry that you feel that maybe he ignored you. You know, it's important to address this with him and maybe even your educational supervisor. Sometimes, you know, they could be very busy. They could be very, concerned about the patient. So I hope you don't take it personally, but it's important to address this, to talk to him about it. Such issues, how do we deal with them? Oh, doctor, that doctor was so mean to me. In real life, get a grip, guys. It's not about your emotions here. Dr. Patel yelled at you. No problem. He told you in orientation that if you don't do your job right, he will yell at you. Why? Because patients' lives are at risk. Okay? We have Dr. Onyango on the other side. He's a known yeller. Get a grip of it. You can't carry all your emotions on your sleeve. That's what happens in real life. But if you're sitting with somebody and they're complaining that the consultant is really not treating them well, okay, let's talk to the consultant about this. You don't want to say things like, can I accompany you to go talk to them? No, people are adults. They are mature. Nobody needs their hand to be held, okay? Which is another thing I find people, it's such a rubbish statement from recall. Can I take you? I can go with you to go and talk to the consultant to do this. Some of these issues the person can just go by themselves. Okay, so it's actually how to apply the words. That is what is important. Okay, next, it is not occupational therapy, because people like to tell me, I need now to contact occupational therapy, and they will look into the matter, investigate with the patient, ask for blood samples, follow up with you. It's not occupational therapy. OT are the ones who deal with fine motor movements. Patients who have strokes, they're not able to pincer, grasp, and physical therapy, of course, you know it's large motor movements. But be careful, it's not occupational therapy, but it's the occupational health department. Okay, then now you can get into, we need to document this in the patient's notes. We need to write an incident report. This is going to assist even other doctors coming in. They can know where high risks are in surgery. Okay, we can talk about it in the next report. Yeah, now the big thing about the post-exposure prophylaxis, antiretrovirals are started within 1 hour. Okay, until that patient tests negative. That's when you stop the antiretrovirals. The patient can tell you, I don't have HIV, I don't have hepatitis B, and I don't have hepatitis C. And then now people say, oh, we don't need to start this patient or our doctor on antiretrovirals. We can't go with word of mouth. We cannot do that, okay? So they have to go through testing, and then once their results come back, then we can stop. But antiretrovirals, triple therapy, have to be within 1 hour. Now it's important for you to ask about his medical history, and I would put it in just to make sure he doesn't have any liver problems, because these buggers are all processed through the liver. Okay, now you've asked about his vaccination status. Hepatitis B immunoglobulin or a hepatitis B booster can be given within 24 hours. We can check his status to see if he's okay. All right. We need to test him for hepatitis B, C, and HIV. He may ask you, when will my results come out? Of course, they are rapid testings and all these things, but technically within 48 hours. Why? It's the NHS. So in that 48 hours, he'll be on the antiretrovirals, okay? And it is important for him to follow up with the occupational health. They will now continue his management. If you don't tell him this, he'll be back to you tomorrow, the next day in the emergency room saying, am I supposed to follow up with you? No. All this now is followed up with the occupational health department. Yeah. If our patient who was undergoing the hernia surgery, if he had HIV or hepatitis or blood-borne pathogen, Okay, sometimes what the consultants say is, this doctor who is, we already have him been exposed to HIV and hepatitis. Okay, he started on the antiretrovirals. We are waiting for his results in the next 48 hours. Okay, during that time, he may not be allowed to scrub into any surgery. Okay, during that time, it may be decided that let him not even draw any bloods. Okay, in fact, what we do for patients or for doctors who have had an injury or nurses who have had an injury, if the flow is okay, if everything is stable, if we are adequately staffed, we usually give them the day off. It's traumatic. We usually say, all right, this is a traumatic experience. Do you want to take a couple of the rest of the day off? It's 2 o'clock in the afternoon. You finish work at 5. Let's see if we can give you the next 3 hours off. Okay. Why? Their minds are not going to be in the job. If they are going to stay on, then for the rest of the day, let them not do any bloods. Let them not scrubbing into any surgeries. Why? The risk of getting stuck again is very high because their minds are not even in it. Okay, so these are just little points of compassion that you can give. Another big thing, occupational health may decide to follow up with them for a period of about 6 months, making sure that they are doing some blood tests just to make sure that they are not, the virus is not replicating in their body. Okay, just to do an HIV test just to make sure. During this critical period, between 2 to 6 months of such an injury, now it is important for you to ask him, are you sexually active, or are you in, I don't want to say you're in a romantic relationship. I would signpost it and I would say there are other things that are very important right now. Okay, are you sexually active? Yes, doctor, I am. It is important. Do I need to know with who, male or female? Do I need to know the route? No. Just if he's sexually active, he needs to have safe sex. Okay. He needs not also to donate any blood during this period until at least we have done some tests and he is negative. Once his results come back, he stops the medication, antiretroviral treatment. Okay. If you can, give him that day off. But that's the essence of such a case with an injury. Don't run and start asking about, oh, you stuck yourself with a needle. Yes. What size was the needle? Was it a large bore needle? Was it a small bore needle? You can ask, get that information after you found out how he is doing. Okay. Now, that's also a good thing that I've remembered. So you found out it's on the right arm, the lower arm. Is it bleeding? Blah, blah, blah. Put a bandage, first aid, give him pain medications. Yes, we need to draw his blood. Then now you can find out, tell me about the needle. Okay. Then after that, you can find out, tell me about the patient. Or you can say, tell me about the patient and then tell me about the needle. It's important if somebody has stuck themselves with a needle to find out, were you drawing blood or were you giving medications? Wide bore needle have a little bit of a higher incidence, okay? And even the time between him sticking the patient and sticking himself, that period is also important. I find it hard to accept this concept that doctors bring to me and they say, well, the risk of HIV is very low. That's a false reassuring. Why are we giving them antiretrovirals? You need to find out, did you stick the patient and immediately stick yourself? Yes. With a wide bore needle? Yes. The chances of you transmitting blood to yourself are so high. Okay. The chances of you transmitting the HIV or hepatitis B or C are so high. But if you stuck that patient and then you put the needle on the ground, and then you went, got some lunch, did all these other things and came back maybe 12 hours later and stuck yourself with that needle, then the risk is a little bit low because HIV cannot survive long on inanimate objects. Okay, it needs a living cell. So that's the thing. The risk of HIV depends on the time of exposure. That instance of sticking the patient and sticking yourself. Okay. Have we had other injuries? How can this case present itself? The other day, unfortunately, somebody threw a needle in the trash. Now, how would you find that out? There's no CCTV camera inside the patient station. It's just an irresponsible doctor or nurse who, or maybe even a patient themselves, who stuck themselves with insulin and threw the needle in the trash. And our poor janitor went to pick up the trash and stuck himself. Now the chances of HIV in that case are a little bit less because the needle has been in there for a while. Okay, but does everybody on the unit have to go for training? Yes, because you do not know who threw the needle in the trash. Okay, so that's a big thing. Be careful on when you're sending people for training, and even at what time you're sending them for the training. Oh gosh, this is another big case. Yeah, there's malingering, there's Munchausen. So there's a different type of injury that exists and doesn't exist. Okay, if you've worked in the emergency room for a long time in a developing country where people are stressed beyond their wits, especially even now during the COVID, the number of phone calls that come in are overwhelming. Hello, doctor, I'm at home. I think I have this sniffles. I think I have cystic fibrosis was another one we had. You think you have cystic fibrosis? What do you mean? I've been going online and just researching some of these diseases, and I think this is what I have. Madam, cystic fibrosis, you just got it at 45 years old? Yeah. Okay, you do sound concerned, but talk to me about some of the symptoms that you're having. Okay, some of them are legitimate concerns. There are others, honestly, we even have lists. This patient calls every single day with a problem. Yesterday they called with a headache. Today they are calling with stomachache. The next day they are calling with leg pain. They twisted their ankle. You tell them, can you please come? I'm scared about the COVID. Can you send somebody to me? Unfortunately, we can't also, because we can't put our doctors at risk to come and visit you for something that you can come to the hospital for. Okay, so psychiatric cases are quite challenging. And that is why it's important for you to remember in psychiatric cases, it's not that they are requiring a diagnosis, even in real life, but that you can manage appropriately and refer to the specialist. Okay, so let's do a couple of these Munchausen's diseases. Samantha Jones, 25, has come to the GP clinic. She has concerns. Excuse me. The medical record shows she comes to the GP clinic every week with a different complaint. There's a problem here. 50% chance she could be sick, so you have to give her the benefit of the doubt. And 50% chance she could be faking, okay? You never just go to a patient and just tell them you're faking. No, okay? You never want to ignore a patient based on your own bias. If Samantha Jones comes in every day with chest pain to the emergency room, every single day and every single shift, we will do an EKG on her and we are going to send for cardiac markers. Okay? That is how it is done. If she goes and she comes back tomorrow, I have chest pain, doctor, I feel like I am dying. Chest pain, yes. Where is it going? To my jaw? Of course, because she has researched. She knows. She will even tell you, doctor, I have typical chest pain. Oh, so you've researched on this disease. Sometimes it's atypical, it's only in my tummy, and I have nausea and I have vomiting. Okay, Samantha, I'm here to play the game. Vital signs, let me draw some labs for cardiac markers. We'll keep you in observation until your CPK and Bs come back and your troponin levels come back. I will do an ECG on you and treat you like a patient who is having an acute coronary syndrome. And then afterwards, when the labs come back negative, like yesterday, we'll talk about this. Okay, now another one. Melissa Smith is in the pediatric ward. Just before her child Tommy was discharged, he developed a fever. The nurse saw her inject a substance into the patient's IV cannula. It happens. People are suffering with very many mental conditions. And the thing is, some of you may get upset and say, why are we withstanding this? We know that the mother is the one who is the other kid, a mother injecting feces into a child's IV cannula, or a woman who keeps rubbing dirt into her surgical wound. Honestly, when we did this surgery, we closed this wound with nice good sutures and then put steri strips on it, and 3 days afterwards she comes back and the wound, the steri strips are gone. It looks like somebody was picking out the sutures, and it looks like there's a brown substance on it. What is going on? People are suffering at different levels. We have to, number one, give them the benefit of the doubt, and number two, we have to treat them medically before we start saying you need to go to the shrink. Okay, now let me just read for you a few of the clues to Munchausen syndrome. Of course, again, where did I get this case from? Blueprint. I'm absolutely loving this blueprint. So I've written so many different cases. Honestly, I may just have to make a new course with new cases from the Plab blueprint. It's quite interesting. Now, NHS, what do they say? Clues to Munchausen syndrome. Okay, they make frequent visits to the hospitals in different areas. So NHS is connected. So if a patient goes and asks for coding in London today and comes and asks for coding in Manchester the next day, and then they're in Liverpool, and then they're in Stoke-on-Trent or whatever, we can trace that. We can find out, okay? So sometimes it may be important to say, let me go through the system. If you're going to discuss this maybe with a consultant, what do you plan to do for somebody who has Munchausen's? Let's just investigate and draw a pattern of maybe how they are acquiring these medications and put an alert on their NHS number. We have to be strict because we have to help them break from this condition, okay? They claim to have a history of complex and serious medical conditions with no or little supporting evidence, okay? Now, they may claim that they've spent a long time out of the country. They have symptoms that do not match the test results. I'm having a lot of pain in my abdomen. I noticed I have yellowing in my eyes. My poo is very light colored and my pee is very dark. Honestly, I'm like, wow, you're asking me all the questions that I should be asking you as a doctor. I think, doctor, I have maybe a liver disease. Yeah, my poo is really light color and my pee is very dark. How do you know the association between those two things? And the conjugation of bilirubin? Samantha. Okay. They have symptoms that get worse with no apparent reason. A patient who was about to be discharged yesterday, the labs are good. We've told them that you're going home, and today they have a fever. Wow. Now our history will have told us that maybe Samantha has been having a challenging, time taking care of this child. Munchausen by proxy, let me just introduce that now, is a guardian, a parent, father, mother, somebody who is in charge of a child who is causing symptoms in that child for a gain, whether it's financial gain or for attention. That, my friends, needs a report to social services. It's an abuse. Okay, so Munchausen's by proxy, a parent who is inflicting these diseases on their child so that they can get attention or financial gain, unfortunately, it may not end up well with them, okay? Having very good medical knowledge, unless they're a physician or they like to, and that's why your social history is important. Sometimes, for this case, I would like to find out from Samantha. So, what's your background? If she tells me she's a physician, okay, then at least now I can give a little bit more points. But if she's telling me she has nothing to do with any health field and she's busy telling me about the conjugation of bilirubin, maybe she's a nice, good reader and she wants to improve her medical knowledge, but that's always very suspicious if somebody who comes in with multiple visits to the emergency room and they are very knowledgeable about their condition, which does not match any of the test results. So you're looking at different criteria in order to say this is a positive prediction, positive predictive value. And I don't want to get into statistics right now, okay? Now, another big thing, they have a solitary lifestyle and they have little contacts with friends or family. So now, are you seeing how my questions will be for this patient? It's not your regular maftosa, medical conditions, allergies, family, travel, occupation, smoking, alcohol. It's more than that. So you have to use your time wisely to ask questions that will clue you in to this condition. Okay, some of them are very willing to undergo painful or dangerous tests. Doctor, I want a lumbar puncture. Wow, even me on a good day or on a bad day, an LP coming requesting for an LP. Anyways, okay. Reporting symptoms that are vague and inconsistent, or reporting a pattern of systems that are textbooks examples, like that unconjugated bilirubin. Okay, or they are saying that I have, this is another interesting one, and we're discussing such cases in we have some journal clubs, where we sit down and we talk about cases, we do some research, really, really nice. The system in the NHS is actually not bad. Pray for the NHS, pray. Hopefully now we'll get more funding after people have seen what COVID can do to our country, yeah? But in our journal club, we're talking about this type of textbook examples of certain health conditions. That unconjugated bilirubin 1 was one of them. And another one presented like a patient who has celiac disease, but not quite. So they're saying, I have a rash, I'm having steatorrhea, calling it steatorrhea, okay? And they're even telling you, doctor, I have steatorrhea. For example, I go to the bathroom and my bowel movements are very fatty and they are floating and they're very difficult to flush. All right, I'm very allergic to gluten and I even have this rash that comes when I'm eating, foods that are having barley, wheat, rye. Okay. And now the giver was that I really think that I may even have a deficiency in vitamin A, vitamin D, vitamin E, and vitamin K, all which are fat-soluble vitamins, because now my condition, is in my GI system, and I'm not able to absorb these vitamins from my daily foods. Can somebody give Samantha Jones a medal? You get a gold medal. You want to take my job, but take my badge. You want to take my job as a doctor? How do you come in with such a detail about a condition that started 2 weeks ago? And what do you want? In fact, some of these patients, you want to say, okay, I'm really impressed that you have so much background information about this. Can I just find out, are you in the have you done any health research? Don't ask people, are you a doctor? Are you a nurse? No. Have you had any health research at all? Okay. How did you come across this information? Doctor, I just like to learn about myself. All right. In your research, did you look at some of the treatments that have been offered for such a condition? Yes, doctor, there's a colonoscopy that needs to be done. Why aren't you talking about your antigliadin test, which is less invasive? Why are we going to the colonoscopy with biopsy first? If you're really interested in diagnosing this condition, why are you not willing to go through the steps? Big red flag. Because anybody coming into the hospital with, even for you, if a patient who comes in with those symptoms, the first thing is not to send them for a colonoscopy with biopsy. Can we just find out if they're testing positive for celiac? Can we rule out other conditions also that can present as a malabsorption syndrome? I'm taking so much time in this because it's important for you to know, okay? Now, unbelievable and very elaborate stories. So now, just by giving you this, and I got this from literally just cut and paste this from the NHS, so I give credit to the NHS website for this management, is now where will you get your questions from? You will get your questions from, you generate questions that give you clues. Okay, now here, signs or symptoms that signs and symptoms of Munchausen may include pretending to be ill or self-harming to aggravate or induce illness. Patient comes in, they collapsed outside, nobody saw them, they came into the hospital, they came in by an Uber, they're saying they collapsed and they hit their head, you're talking to them, they are looking dizzy, you do your vital signs, they are fine, you take a blood sugar, it's within normal limits, you do a head CT scan, everything is absolutely clear. You do all tests possible, but every time you go in there to talk to the patient, a few minutes ago they are looking at the TV, but when you walk in, they are pretending that be very careful about such patients. Now, lying about symptoms, tampering with test results, for example, heating a thermometer to suggest a fever, or adding blood to a urine sample. Has it happened? Yes, it has. Self-infliction, for example, cutting or burning themselves, but you have to make sure that this is not a suicidal attempt. Okay, so you have to go in with a very big spectrum, because a patient who is coming in and they cut themselves, you just don't want to say this is Munchausen, let's discharge them. It could be a more serious problem than that. Okay, aggravating conditions like, for example, I said rubbing the feces into the wounds, causing an infection or opening wounds. Now, if this was a case where a nurse has told you, you know, I was in the room, okay, and I saw Samantha take out a syringe, okay. First of all, last week I saw her trying to fiddle with the sharps container, and I saw her working on it, and I asked her what is going on. She said nothing. So there was some evidence that she may have a needle or something. But today, I saw her injecting something into Tommy's catheter. Hello, Samantha. My name is Dr. X. I'm one of the juniors in this pediatric clinic. Can I just confirm your relationship to our patient? He's my son. What's his name? Is Tommy. Last name and age, Tommy Smith or Tommy Jones, and he is 10 months old. Okay. I can see from my note the nurse saw you inject a substance into the patient's IV. Wrong. I can see from my note that Tommy has been admitted to us. Can we just do a bit of a recap as to why he's here? Well, he was born premature, or he's been having a fever, I don't know what's going on, or I noticed that he's having blood in his urine, doctor, or he has this rash, or he has this fever. Okay, I noticed that we were even preparing him for discharge. So everything seemed to be okay, but now he has developed a fever. Yeah, let's talk a little bit more about Tommy's health. He's 10 months, you said he was born prematurely. I'm going now into birth history, okay? Any other complications with him during birth? So he was a preterm baby. How long did he stay in the hospital for? Couple of months, and then we went home. Are you the only one taking care of him? Social history. How are you doing? How are you coping? Because then there may be some telltale signs in Samantha's life that show you she's at a high risk for Munchausen's by proxy. It's hard for me. I have a job in the cafeteria. It's hard for me to make ends meet. You know, Tommy was not a planned pregnancy. You know, his father ran away as soon as he heard that I'm pregnant. Things are difficult. And now I'm here with him in the hospital. Or I'm so afraid. I don't want to go home. I don't know what I'm going to do for him. All these telltale signs you can get with your data gathering. So to me, getting the clues are more important than her diet and her exercise, are more important to me than was Tommy born vaginally or by cesarean section. He is 10 months old, for crying out loud. Whether he came in by boat or whether he came in swimming across the river, and this is a nice joke I usually give, or whether he came into this world in the trunk of a car, he is here, okay? Some of these questions have no place, yeah, in this setting. In a case of jaundice, would I want to find out the mode of delivery? Absolutely. But now, no. Okay, coping is important because I want her to tell on herself. I want to see the environment at home. Was Tommy a plan for pregnancy? If not, ding, that's a risk. Okay, and then now we can get into, he's supposed to be going home today, but he just developed this fever. I'm trying to think causes of a fever, and you want to talk to her about it. There are certain causes of a fever that can just happen. Either they've developed an infection, or maybe we've missed something in their lab work. I am going to check his records to see if I can find any clues. Okay, have you given him anything by any chance? All right, no, doctor, I've not given him anything. Okay, because a fever can be caused by environmental causes. Also, it could be caused because maybe we've skipped on an important result from him. So I will go and talk to my consultant and look through it. And we're a very close-knit team. Now I'm starting to break the news. We're a very close-knit team in the hospitals. Our nurses are very vigilant. Our nurses really pay attention to each and every patient. They know what is going on. And I'm sorry to bring this up this way because it's important. Our nurse notified me that she saw you injecting a substance into Tommy's IV line. Can you keep quiet, my dear doctor, and wait for her to speak? You are just throwing the question out there and looking for the response. Of course, the response you're going to expect is, no, I've not done it. How can she say that? Which nurse told you I need to go and sit? No. The importance is not even speaking to the nurse. The importance is finding out if anything was given to Tommy. I'm not here to accuse or to judge you. I just want to get a big picture. And when a nurse comes and tells a doctor anything, or when a nurse comes and reports, the doctor has to look into the matter. The nurse could have been mistaken, or it could have actually happened. But it's important for me to know the truth. Okay, you can say it in that way, but you're not there to fight, and you want to show her, I'm not accusing you, I'm just gathering information. Okay, no, doctor, that nurse is a liar. I've not injected anything into the patient. Okay, because if this has happened, then it could actually cause a fever. It could cause a decline in their health. If you are concerned with the treatments that you are giving in this hospital, I would want you to voice your concerns. But if you have given anything to the patient, please let me know. I can even just verify with the nurse to see, if she can just come in and verify again that indeed it was you that she saw. Now, if the woman says, I injected a substance, oh, I feel I feel a little bit bad, because then I get upset. And most people will get upset because why are you putting your child through all this? You may want to say, okay, please tell me what substance was it? So first of all, let's not get upset with Samantha. What substance was it? Doctor, it was just, I injected some blood into their Foley bag, or I injected some water, or I put some salty water and injected it, or I took, whatever. People are crazy. I coughed and put some saliva into a syringe and I injected it into them. Okay. My reasons for asking this is, so first of all, thank you. I appreciate that you have, confided in me. Is there a reason why? I need to know why you may have done this. I'm afraid of going home. I don't know why I do it. Most of the time, do these guys admit they don't? Okay, so it's a very, very tough situation. But I would ask, is there a reason why? Was there an outcome? Is it really, really challenging to take care of the child? Because it is not appropriate to cause him all this distress because you don't want to go home. If you're having a hard time taking care of him, there are some step-down programs that can assist with taking care of children until maybe you can get yourself back together. You're saying you're not working, you're saying you don't have money. There are some programs that have been set up for children that can help families financially, that can help you if you're thinking that really you do not want to take care of your child. There are some programs that I can refer you to. We need to talk to the social services. That's how I would deal with it. But now this is a more concise way, right? Because there are differentials as to why people lie that they're sick. Sometimes it's just a personality disorder. Okay, maybe stemming from narcissism or histrionic personality disorder or dependent personality disorders. Go and look into psychiatry, please. This is your homework for today. Go and type in personality disorders and read through them. Okay, there are different categories. It could be this person has experienced some trauma and they're just inflicting it on their child. So this case would move from an 8-minute case to a half-an-hour case. And so you have to realize by 2 minutes, you have to do your differentials, okay? I'm sorry, you have to do your management and your referrals, okay? But these are some of the things you want to look into. Now, if it is someone who is upset with the medical system, of course that has happened. It's actually on the NHS. There are some people who want to get back to the NHS or who are just unhappy and they want to make your life difficult. Okay, diagnosing Munchausen can be challenging for medical professionals. People with the syndrome are often very convincing and skilled at manipulating and exploiting doctors. You cannot handle this case alone. So that's why a referral is important. What would you do as an FY2? Do your differentials and make sure you get that good social history. Touch a little bit on psychiatry, yeah? Find out a little bit about their trauma. Now, attention seeking, financial gain, little bit. But in the end, would I tell them, I think you have Munchausen syndrome and you need to see a psychiatrist? Absolutely not. The words Munchausen actually never come out from our mouths. These are things we discuss in our meetings as, goodness, this could be a Munchausen case. Okay, but you want to find out with a physical exam and your lab work. Don't send away a woman who comes in and says, I have chest pain, just because she came in 2 days ago and has chest pain. Could it be that maybe she's actually having chest pain and having a heart attack? It could be. So you have to do your labs and rule out your alarm diagnosis. Don't be confrontational, okay? And a big thing, if you were to discuss this, let's say, with a consultant, what would you do for this patient? So talk to the patient and then discuss it with your examiner. Well, I have many differentials, examiner. First of all, it could be a medical condition and it could be of a Munchausen origin, but I need to find out the etiology. Could it be from emotional trauma, physiological? Could it be sexual? Could it be because of neglect? Could it be a psychiatric disorder? I cannot manage this on my own. I need the assistance of my team and also a referral to a psychiatrist. If the child is in danger, social services, okay? But you want to start by saying alarm, rule out alarm diagnosis first, and then you can move on. It is important for people who are highly suspicious of Munchausen's to get a key staff. So, for example, I am the key staff of one of this is from a different hospital. Okay, a guy who frequently comes to the hospital and maybe I'm the only doctor he talks to or listens to or blah. They will keep me as his doctor and maybe somebody else and another nurse. So we know when Tommy comes into the hospital, we know he's struggling with homelessness. When it gets cold outside, he comes in and he complains of chest pain. He comes in at around 10 p.m. at night, knowing that we cannot discharge him after midnight. Okay, so this is Tommy's team, led by this registrar, has this junior doctor and this nurse. If these people are not around, then team B will take care of him. That way we cannot do unnecessary tests for him. Okay, he comes in, oh, I have chest pain again. Okay, let's do your labs. We are going to keep you here, get you a meal. The next morning, I'm much better, doctor. Okay, we'll see you again. Yeah. Now, CBT, family therapy, sometimes you may have to go deeper into such cases, especially if it is coming from a childhood perspective. But remember, social services is very important for Munchausen's by proxy. Okay, good. Now, let's get into COVID cases. I can't believe I've taken so much time on that case, but it's good for you to know it, yeah? And I've discussed different ways that it can come in, so at least you'll be well equipped for working for the NHS. Now, a long time ago before COVID, can I discuss this and then we'll go on a quick break? Yeah. A long time ago before COVID, any person who came in with a persistent new cough, fever, 37.8 or above, okay, dyspnea, flu-like symptoms, aches, we would green zone, amber them, or red zone them, depending on breathlessness. So anybody coming with shortness of breath, of course, or marked dyspnea, we would actually keep them in observation with close monitoring. Yeah. Now, because of COVID, if you are presented in your OSCE or in your examination, whichever clinical exam that you're taking, a patient coming in with respiratory symptoms, please, number one thing is we are putting them in a separate room, and we are putting on our PPE. Right now, if you're working in the emergency room, you already have your PPE on. So every type of patient who's coming in with a fracture of the knee, of the arm, or whatever, we are all gowned from head to toe. This is how COVID has changed medicine. Will it change? Yes, it may. Okay, but everybody is gowned and gloved, including our lab technicians, nuclear medicine. Everybody is gowned and gloved. Now, the thing is, looking at the situation, I'll discuss these cases that we have dealt with in this season. Okay, I'm calling it a season because we are hoping it's going to end. Yeah. Someone has come in with shortness of breath and respiratory distress, fever, cough, shortness of breath, muscle aches. Okay. Someone has already been admitted to our ICU, is on ventilator support, he has multiple comorbidities, MDT has decided for palliative care, talk to the family because of COVID. Samantha Jones, 45, has come, has some concerns. She's either calling on the phone. My husband has COVID, I don't have it. What am I supposed to do? I read that I should start taking what is this medication? Chloroquine. I saw that I also using hand sanitizer and even drinking it. It was said by the president of one country that these are appropriate treatments. These are the things we are dealing with now. Okay. So if I am to talk about this case with palliative care, let me give it to you in how we are doing it now, okay? It's very sensitive. Many people, of course, have perished because of this condition. People are coming in with even a simple flu and they're thinking they're going to die, okay? So unless a multidisciplinary team has said that this patient is going on palliative care, the words end of life should never come out of your mouth. You should never give the end. The end prognosis of every human being is the grave. We know that. Do we need to be reminded all the time? No. And we even had a bit of training because people are coming in with coughs and colds, and nurses are saying, I'm sorry, if this is COVID, the outlook sometimes is not good. You may never go back home and see your family and be like, oh goodness, what are you saying? Okay. End of life care is just not discussed off the cuff. Okay. So now let's deal with this case and then I'll give you a break. Peter, 60, on ventilator support in the ICU, has multiple comorbidities. MDT has decided for palliative care. Update the family. So you walk into the room and maybe there are 2-3 people. Hello, my name is Dr. X. I'm one of the junior doctors in this department. Can I please know the name and the age of the person you're concerned about? Yeah, we are here because of our dad. His name is Peter. He's 60 years old. Okay. And can I just know your relationship with him? I'm his son and these are my 2 sisters. So we are his children. Or I'm his wife and these are my 2 children. Okay. I'm very sorry. Okay. It has been quite a challenging, season for all of us. How are you all coping? Doctor, we are coping okay. We are just trying to do our best. Yeah. I was going through the note and I noticed that Peter has been on the ventilator and he has multiple conditions he's dealing with. Before I can give you an update, can we just do a bit of a recap about his health conditions? Yes. What medical conditions does he have? That's where you start. Don't start does he have headache, throat pain, eye pain, chest pain? That's review of systems later. Okay? It may be not even necessary. Okay, medical conditions, he has high blood pressure. He also has questionable lung cancer. In fact, all these respiratory symptoms happened a few days ago. So we are wondering if the cancer is back. We're wondering if it's this COVID, Doctor, please, can you give us an answer? What is going on? Okay. Now, because you have asked for concerns, you have to deal with the concerns. Never leave a patient hanging, all right? You can say, getting a good, clear picture will help me answer your questions better. Much better than just saying, can I answer my questions first and then I'll answer your questions later? No, that's doctor-centered, yeah? So he has had hypertension, he's had lung cancer. When did his symptoms begin? 3 days ago. What were his symptoms? Shortness of breath. He was coughing. He had such a high fever. We know COVID is going around, doctor. So we brought him here to the hospital. Nobody has told us anything. We have been waiting in the emergency room for so long. You're the first doctor we are seeing. I apologize. Okay, it's a difficult season for all of us, but I'm here now and I will answer your questions and give you a full update. So he did come in with the shortness of breath. Sometimes when the shortness of breath is too much or when the patient's lungs are not able to adequately exchange air for them, we have to assist them with a ventilator. So the ventilator is assisting them to breathe, okay? And usually how it assists them to breathe is that we put some tubings into their windpipe that goes into the lungs to help expand the lungs. Little bit of explanation, don't overdo it, okay? He has been in the ICU since he came in. And you have told me that he has had challenging conditions of high blood pressure for the last 5 years, and he's also had this lung cancer for the last 5 years. Okay, so even coming into the hospital, he was not doing too well. Are you the ones who are taking care of him at home? Yes. So how was he coping? Was he seeing specialists? Yes, doctor. Was he on any medications? Yes, doctor. But now we don't know what is happening. Okay. The thing is, why have I gathered data on this guy? Because I'll use that data to help manage the palliative care, okay? This is now when you can break the news. After a couple of minutes, you never just walk in and say, your patient, we're not gonna do anything for you, I'm sorry, okay? Then now you can break the news. Thank you for telling me about his medical condition. It seems to me that he has been suffering for a long time. And the results show that maybe he tested positive for COVID. I forgot to put that here, okay? And someone having COVID and they've been having some underlying issues, sometimes the outlook is not too positive, or sometimes the outlook is really not what we expect, or the outlook sometimes may be different from what we hoped for, okay? We have reached a point where medicine, okay, or all the treatments we have given to him have reached their limits, or we have reached a point where any additional intervention, be it medically, okay, be it surgically, will not give any added benefit. Where am I getting the words from? If you've taken my courses in the past, I say go and read. Read and look up information so that you can build the words, practice them. Okay, go look up palliative care websites in Canada, in the USA. Watch videos on YouTube of how to break palliative care news to a patient, because you will have to do it as an FY2. People's children are coming in and not leaving the hospital. They may go on palliative care. The elderly, men, women. You have to know how to break this news. Okay, now we have done what? We have assessed him. You've told me about his comorbidities. He's not doing too well right now. And we have reached a point whereby any additional treatments are not in his best interests. Any additional treatments will not give us a promising outcome. Any additional treatments may actually accelerate his current condition. So many ways to explain it. Choose one. Okay. Whenever we get to this point, whenever a patient is suffering from multiple comorbidities, we understand that they need more of a supportive team. So we have increased the capacity of the people who are responsible for his health. There is the general medical team, and now we have a multidisciplinary team, including the palliative care specialists. What palliative care does, okay? Do you want to talk about this team? Yes, talk about the team, my friends. Talk about their consultants. Talk about their social workers, their therapists, their dietitians. We have ST, OT, PT, speech, okay? You want to talk about a social worker. You want to talk about this community palliative care, but this is only for somebody who's been discharged into the community. Yeah? You don't know whether this patient is going to make it outside of the hospital, but you want to introduce the team as being an extra form of support at this time. This is what your father needs, okay? Progressive advanced disease, limited prognosis, poor outcomes with advanced treatments, no added benefit from this point. It is in their best interest for us now to stop further medical treatment and not even look into any advances of medical treatment because we may not get favorable outcomes. Okay, now whatever treatments we have, we will not prolong his condition. Another way, I'm having too much fun with it. Okay, our focus is to achieve the best quality of life for your father for as long as we can in this situation. What are you going to do? What are the key areas? Physical. So now the main principle is to make sure he's comfortable. Pain. Don't start saying, if he's drooling, we are going to suction his mouth. If he soils himself, we are going to change his depends, or we are going to spoon feed him. I don't know why people talk about these things. That's too detailed. It seems like maybe you're pulling outside information. Nobody's talking about him soiling himself and him needing suction. Talk about pain management. Make sure that he is comfortable. Okay, make sure that his condition does not excessively deteriorate and he suffers. Yeah, the multidisciplinary team, you have to take your time and be compassionate, but not sad. So some people end up shedding a few tears when they're talking to patients about palliative care. I know you are a good doctor and you're compassionate, but be strong. They're the ones who need the help, and sometimes we do get a bit engaged and we may choke up a bit and have some sniffles, but you're the one who's supposed to be their support person. We never apologize for palliative care. I'm very sorry, there's nothing else we can do. No, palliative care is the solution, and it's a good solution. So don't be so apologetic. I'm very, very sorry. Death is imminent. There's nothing that we can do now. You can talk to my consultant, but the decision cannot be reviewed, or it cannot be revoked. Or I'm telling you things that are here in the mocks, and they really ruin a case. Okay. Now, do you want time for them to talk about it? Yes. Do they have questions? Yes. Unfortunately, in the early stages of COVID, were people dying alone, with surrounded by strangers? Yes. There are people who are, and wonderful nurses, what they would do is, because people are self-isolating at home, this person was brought into the hospital, and they've died. We have had to call people at home to tell them. And some people have not even buried their loved ones. This is so crazy, the way this disease has really changed our healthcare. So would you want to prepare to break bad news to somebody over the phone? Yes, you would want to prepare with that also, because it's something that we have had to do. Some of them have come into the hospital and demanded, I want to see my dad, I want to see my mom, even in COVID. What do we do for them? We dress them up in PPE and they go in and they say their goodbyes. Okay, but it's tough, and you may find a case like this because it's still current. Okay, be prepared. Let's go for our break. Let's go for a 10-minute break. I'm thinking that maybe we'll do our mocks. We'll do our mocks, and then I'm thinking I may continue and start day 5 today. So some of you may not be able to stay on, but I'll after the class, I'll log off, take maybe half an hour break, and then come back and do the day 5 session, and then post it for you so that you'll be able to review it even for tomorrow. Okay, let's take our 10-minute break, come back, and then we'll continue. Okay, that's see you soon. We are back from our break. So let's continue with this COVID management. A good thing with the NHS, people were given the chance to either, assist in their capacity. Either you can be in the front line, either you can be an educator, or you can work in triage. So triage doctors, mostly those ones who maybe have little children at home, they are afraid that, if I'm exposed, they might be exposed. Give me something where I'm not going to be fully exposed. So many people are put through guilt trips, feeling that I'm a doctor, I'm supposed to be in the front line, but I have a family. So the NHS really tried to accommodate physicians in their capacity, or even healthcare workers in the capacity that they could work in. Okay, they even called and they said, we have opened Nightingale, are you interested in going to work in the COVID center? Some people agreed, others didn't, and there was no judgment about it. It's in your capacity, what can you give? So I got this case from those who were working triage, okay, because the number of phone calls was quite overwhelming. Now, you are working in a triage center, or let's say you're one of the doctors at the desk and somebody calls, hello, my name is Samantha Jones, I'm 25 years old, I'm so overwhelmed with this COVID thing, can you please answer a couple of my questions? Absolutely. Can I just get a bit of details from you, Samantha? What's your last name? Yes, and your date of birth. This is my last name and my date of birth. Hello, my name is Dr. Liana. I'm one of the juniors working in triage today. Okay, thank you for your phone call. Just before we get into detail, just before I answer your questions, please just give me a telephone number where I can reach you just in case this call gets disconnected. Okay, doctor, by all means, my telephone number is 1234567. Okay, I can answer your questions. How do you say to somebody, can I confirm where you live? There's no need. She's the one who is calling you. She's just calling you to find out a few questions. You don't need her NHS number. You don't need to know where she lives. Just get a phone number just in case you get disconnected. It's a general phone call. Now, there were other cases or other phone calls that were coming in to the center, let's say from a care home. And honestly, the hardest hit areas in this season were care homes. Because a care home, they are there for rehabilitation, suffering with Alzheimer's here and there. They have a broken hip. They are trying to be okay. The staffing really doesn't need to be very skilled. So when they were hit big time because it's close quarters. You're having everybody eat in one big dining room. You're having them use the same bathrooms. They are having visitors coming in to come and see them. So the place is not shut down. They're using the same utensils. So unfortunately, the care homes, the nursing homes were really, really hit. It was so sad. One day I was jogging around and I saw a couple of ambulances parked outside one of the care homes near my home. And when I asked in the hospital, they're like, yeah, they are just posting ambulances outside care homes just in case, because by the time the ambulance drives to the care home, takes the patient and intubates them and brings them to the hospital, the person has gone. So they're just prophylactically putting ambulances up outside. Such a sad season, but we'll get through. Yeah. So there's that case of just a simple Samantha who is in her home who has questions. And then there's another case where a skilled care worker or a carer is calling and saying, hello, I need to talk to a doctor. Please tell me what to do. I've been taking care of a man here. His name is James Smith, and he's having respiratory symptoms. We were told to self-isolate until we start having respiratory symptoms. This is what is going on. What should I do? Send him over. What does he have? What are his medical conditions? Does he have, give me a bit of a history. Anybody else around him who is sick? Any exposure? What have you done during this season to prevent counter exposures with your patients? We're just having gloves and masks. Is your institute on lockdown? Yes, but we have some patients who are being visited by their families. Well, send him to us immediately, but don't forget to send the patient's notes. Do you still want to gather data? Yes, because when he comes to you, you want to get a report from that skilled nurse or that care worker, and then look at his medical record, and then even say, can you have a family member call us, because we have some family questions maybe that they can ask. But would you want to know that this guy has had a stroke? Wouldn't you want to know that he was maybe on some antibiotics? Wouldn't you want to know that 10 other people have been affected with COVID? Those are the types of questions you would ask in that scenario. Okay, a transfer from one institute to another, you are allowed to break, in fact, there's no confidentiality, it's a report. It's just that they are in another place and you're in another place. What are you going to do for him when we send him? Tell her what you're going to do. We'll do our investigations, we'll do blood work. If his respiratory status is decreasing, we'll manage that. Especially because he's an elderly patient, he may be admitted. And now, because of the comorbidities, sometimes if the respirations are, if he's really having a stress in managing his respirations, we'd have to admit him to the specialized unit. Do you have to tell them exact details? Full blood count, LFT, RFT, chest x-ray, intubation, measuring of ventilatory support. I'm going to get, who asked you? Please, simple things. Because some people also get into trouble because the skilled worker will tell them, can you just give me an overview of what is going to happen? I cannot talk to you because we are under confidentiality. So now, confidentiality was okay for you to gather information from this care home, but now giving them information, now you're bringing the confidentiality card. It is allowed. It is allowed. Please, 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 please. I don't know how many pleases I say. I say in this exam. Oh, excuse me. I don't know how many pleases I say in this exam. Now, big thing. Samantha Jones. Let's talk about her because we've had almost 100 Samantha Joneses who are calling us because of COVID. And here are some of the questions. Now, hello Samantha, I'm one of the doctors. You're in Manchester. How are you doing? Social medicine. I'm self-isolating. My husband has the COVID. Was he tested? Yes, doctor. He went and he got something done in his nose and it was positive. Okay. Who else is in the home? Me, my children, and my elderly grandmother. How are they doing? They're doing okay. It's important for your husband to self-isolate to prevent it from spreading to vulnerable populations. How is he doing? He seems to be doing okay. Okay, good. Was he given any medications at all? No. He was just tested positive and we were told if he's getting a hard time breathing, we should come. Okay. I also tested, but I tested negative. How can I test negative and he tests positive? Samantha, only God knows that question. What are you asking? Okay. So you want to say to her, there are different reasons. Come in with the blanket. There are different reasons why some people have caught COVID and others have not. Vulnerable populations have gotten the disease, and even non-vulnerable, healthy people with a high immunity have gotten COVID, and others who are even struggling with comorbidities have gotten a negative result. So there's really no way to say why some people get the virus and why others don't. And it's still such a novice disease. Well, coronavirus has been there for as long as medicine has been around, but COVID-19 has proven to be quite the challenge. I'm glad that your husband is recovering, and I'm glad that you don't have any symptoms, but it's important for you to remain protected. Okay, so continue to self-isolate, because if you have one person who is sick in that home, everybody should be in that isolation until the symptoms subside, and maybe you can all come and get some negative results. Fine. How else is everything? Are you able to maintain your basic needs? Food, yeah, okay, that's good, because even now you can have delivery systems to get food to you in your home. That's what we do. Okay, find out about their coping, their basic needs. All right. Now, symptoms, of course, you found out. You've already even given elderly and children. What is your safety netting to this woman? Hand washing, mama. Hand washing. Don't leave the house. Have Tesco or Morrison's deliver to you, and maybe put a sign on the door for social distancing. Yeah, and we are here to answer your questions. Now, she may have some questions like some of them have asked. Dr. Donald, I saw on TV, he has said that we should take this hydrochloroquine. And, I also saw somewhere that crushing ginger, lemon, and honey can really boost my immunity. Really? Can we... Why don't you put that in a bottle and sell it? Come on. Where are you getting this information from, Samantha? The internet. The internet is a good place to get information about everything else in life except for medicine. It's important to talk to a physician, and I'm glad you're calling us today. Please stay off mainstream media when it comes to COVID disease, because many people have been misled. But I don't understand. He's a leader and he has told us to take chloroquine. I said, sometimes, okay, even leaders may be misinformed. Is this a time for you to talk about Dr. Donald and how he didn't get a medical degree? Okay. A doctor has to be non-biased. It's not time for you to trash talk a president. It's not time for you to give your views. And some of my colleagues have gotten into problems. We respect authority because authority is given by authority. So I have nothing to say about Dr. Donald, but that he could be misinformed. The best place for you to get good quality information that is evidence-based is from the NHS guidelines, okay, and from other guidelines from the NIH also, okay. So I can send you these links. Do you have a pen and paper, Samantha? Write this down. Stay away from mainstream media. I also don't want you to be bombarded with so much of the fear and uncertainty that the media is pushing. You know, we have had more positive cases than the deaths. So, if, for example, if you're having 100,000 cases who have tested positive and 20,000 who have unfortunately died, where are the 80,000? The media usually doesn't push for good news most of the time. Mind your own business, Samantha, switch off that TV and turn off that internet. Sometimes we've told patients that, okay? But please, don't get into that conversation. Don't drink hand sanitizer and don't take hydrochloroquine, okay? Now, where did the COVID come from? You called me to ask me where COVID came from. Corona has been around for a long time. COVID-19, coronavirus, 2019 is when we started seeing a spike in the cases. There are multiple viruses in the air at every given time. Unfortunately, how we have managed this pandemic, you know, has caused us to have frequent cases. But now everything seems to be in control and we are bringing it down, whether it came from whichever province in Kenya or whether it came in from whatever province in Zimbabwe, nobody cares. It's here now. Okay. Now, how can my husband test positive and me negative? What are there chances of me getting it in the future? Viruses mutate. For example, if I can give an example with the influenza virus, do you know there are so many types of influenza viruses? So even though you get a flu shot, you can get a different strain of the virus. So we are not too sure about the types of strains of COVID, right? There are some that are associated with severe acute respiratory disease, SARS. There are some that are linked with just mild symptoms, okay? So the thing is protecting yourself from getting the virus in the future. Number one, hand washing. If you're going to go outside, you need to wear a mask. I know some people are saying masks are not necessary, but a mask is necessary for your protection and to protect others. So if I wear a mask in public, I am protecting you, okay? And I am being protected from you. So it's a two-way process. Please wear a mask with public transport, in the supermarkets, and there's some masks that you can even prepare for yourself with some good material at home, just to make a barrier, okay? Do I need to invest in an N95 mask? If you can get your hands on one, but honestly, you know, people have taken advantage of this pandemic and have made masks and are labeling them as N95, charging people 200 pounds for them, and it's just a plastic bag. You know, self-isolate, number one priority. Wearing a mask, second priority. Third priority, social distancing, okay? It's a bit hard not to handshake, but prevent yourself from this. Don't invest in a 200-pound mask. Give that money to the NHS. Come on, okay? Other thing, is there a blood test to make sure that I am immune to the disease? Now, there are some questions that can come up that now you need to go and research. Sources, WHO, CDC, NIH, and NHS. These other sources are quite complicated because they're using a lot of jargon, and it just breaks it down for the patient. So I've kind of gathered a few points here. Now, medication that is used, this is from, I think, the WHO, remdesivir, okay, in hospitalized patients with an SpO2 of less than 94% on room air, or those who require supplemental oxygen. This is what we are giving, remdesivir, okay? Now, sometimes we can give dexamethasone for, okay, patients who are mechanically ventilated, and in patients with COVID-19 who require supplemental oxygen but who are not mechanically ventilated. So there's a little bit of, some of my consultants in the ICU are just like, No. And then there are different techniques. Should we ventilate them, prone ventilation? Should we do different types of tidal volumes? All that stuff you can get into it and just read for your own background, yeah? Excuse me. Here you are. Dr. America, the panel recommends against the use of chloroquine or hydroxychloroquine for the treatment of COVID-19, except in a clinical trial. No, we are not using it in this country. Out. Okay, good. Another big thing, all these are like dual therapies. You can always read that. ECMO, I told you about prone therapy. You can read all that on your own time. Now, here, good. How about my child? You know, is my child at risk because they are young? Well, anybody whose immunity is not fully developed is at risk. Some children get it, some children do not get it. Why am I being so vague? Because it's still vague. So you cannot be super exact on something that is not yet gone through evidence-based medicine. We are all struggling to put blocks together. What time is it? Are you kidding? It's 1:56. All right, we'll have to do our mocks maybe tomorrow. I have to finish this COVID thing, yeah? Okay, now a big thing here is that insufficient data is available. You can use that as a clause. Insufficient data is available to clearly establish risk factors for severe COVID disease in children. Okay, please. Immunocompromised may be at a higher risk for severe disease. Yeah, children with high risk factors recognized in adults, including obesity, diabetes, and hypertension, may be at risk. Good, good. Next one. Here you are. What did I want to talk about in this case? All this is just again with your oxygenation and ventilation. You can also look at that. But there's a lot of information, guys. Please just go and read a little bit on it. But if Samantha is asking you some certain questions, it's important for you to know how to deal with them. Okay. What other thing did I miss from Samantha's questions, what we've heard about? Is there a blood test to make sure that I'm immune to the disease? No, I read it somewhere here. Let me just make sure I can read it to you. Testing. Current serological tests have limitations in their performance and their ability to determine whether a patient is immune to SARS-CoV-2 infection. Okay, in light of these limitations, the panel recommends against the use of serological testing as the sole base for diagnosis for acute SARS-CoV-2 infection. So there is no blood test that is recommended to show that you are immune to it. All these blood transfusions, what if I'm immune to it because my husband is immune to it? It's a virus, darling. It's a virus, okay? Who knows how many strains there are now, especially that, you know, the social distancing is now a thing of quotation. Put on your mask. When you're walking around, be vigilant. Stay alert. That's what the NHS says. Stay alert. If you're walking into a crowd, cross the street and stay away from people until we are sure that this thing has subsided. Are there going to be future attacks in the, you know, we're told that there might be a second wave in the future. You know, Samantha, not much is known about the future. We are glad that we are alive today. So we just have to do the steps that will protect us in the moment now. Who knows, in the fall, we may have another spike. I really pray that we don't have to go through this again. You know, and if we are to go through the same ordeal again, I hope we are better prepared than the first time. What can you do now for yourself and for your family? Stay home. Stay home unless you have to leave. Okay, that's what we are advising people. And another question that came on the phone is, I feel so bad, doctor. The doctors are saying one thing, our prime minister is saying another thing. The news is saying another thing. What am I supposed to go home to do? Should my children go back to school? Should I go back to work? Number one, if your livelihood can be obtained by you being in your house, stay home. If you're in a capacity to continue to educate your children at home, stay home and do it, mama. Stay home, okay? I know the government is saying that the pubs are open, public transport is open, the cases are declining. We cannot control people. There are people who are positive for COVID and they are out in the public and they are not wearing masks. If you get into such an encounter and you get the virus, your chances of fighting the virus depend on so many things. So the best thing is to stay on the side of caution until we get a clear picture. Since it is a disease and there are medical personnel who have studied about epidemiology and have studied about the rates of diseases and the R and all these other things, follow the guidelines of the doctors. I'm sorry, follow the guidelines of the doctors and not the media. Stay home, okay? Good. Now that I've taken all your time, let me see, there's still this case I wanted to go through about the COVID emergency patient, because we have had to follow specific infection control when it comes to COVID. Let me just do this case and then we'll sort out ourselves with our mocks tomorrow, and I hope that you'll be able to make it for our final day. That way, when we're done with COVID, we are done. Okay, so COVID emergency patient, a patient, Tommy Jones, 35, brought to the emergency with shortness of breath, okay, respiratory distress, fever, cough, shortness of breath, muscle aches. You should already be in your PPE. And what PPE do you need? You need here, the panel recommends, this is the panel from, I think, the CDC, fit tested respirators, N95, or a power air purifying respirators rather than a surgical mask, in addition to other PPE including gloves, gown, eye protection such as a face shield or safety goggles. Usually, actually, the PPE depends on the type of NHS you're working for. PPE that we've gotten now, some fantastic gloves. So there's a glove that will not leave your body, okay? You have gloves on and then now you can put your other regular gloves so that when you take, there's no part of you, there is no part of you that will ever be exposed to the patient, okay? The N95 is absolute must. This is the PPE you would have to have on. Now, James is short of breath. What do you want to do? You cannot move away from ABC in COVID. ABC is the standard of medicine: airway, breathing, circulation. So number one, put James on the monitor. Management in emergency remains the same. What are his vital signs? Oxygen level 80%. James, are you a smoker? Or do you have any lung disease at all? Have you had trouble breathing in the past? Or you're trying to see, can he have the capacity for high flow oxygen? Yeah. Oxygen level 80% from the monitor, intervene. I need to give you 100% of oxygen via a non-rebreather mask at 15 liters per minute. I'm sorry, you're going to feel quite a large flow of air coming at your face. Take deep breaths in through your nose, out through your mouth. Where is your hand? On his shoulder. I am right here with you. I will continue to manage you until I can get help from a senior doctor. Let me see your vital signs again. Now your blood pressure is what? Let's say if it's a low blood pressure, 80/60. Put your 2 large bore IV cannulas, give him a fluid challenge like I mentioned before. We never just flood people with 2 liters of fluids, okay? That oxygen, how is it? It's 80%. It's really not improving. that much. And now here is the thing. These patients have deteriorated so fast. So you could be putting in that IV cannula and he was 80%, now he's 70% and he's barely responding. As an FY2, you need to know how to protect an airway. So here are your vital signs. You already know how to look at vital signs on a monitor here. There's your heart rate, your SpO2 is your oxygen level, there's a pulse, that's an arterial blood pressure, that's your pulmonary artery pressures. These two you might not have them initiated because they're quite invasive, okay? An arterial line, Swan Ganz catheter, and tidal CO2 after you've intubated a patient, but pretty much this is how the monitor looks like in the hospital, yes? Good. If you are going to put oxygen on James, okay, and you need to make sure it's secure properly, so put it on the patient. And even in our mannequin labs, we are tested on such things with a mannequin. Are you just slamming the mask on? No, you're putting it on and you're asking, putting 2 fingers underneath the straps. Is this comfortable for you? Or I'm just going to make it a little bit tight. Make sure you pinch the nose area so that there's no air escaping even from the chin. Yeah. Do you want to listen to those lung sounds? Absolutely. Can you listen to hear if there's any distress? What if he's having another problem and it's not COVID? What if his lungs are filling up with fluid? What if it's a pneumothorax? You need to listen to those lungs early enough, okay? Good. Where are my adjunct treatments? This is your non-rebreather mask. Not too bad, okay? It has a one-way valve and the bag at the end. Yes, there's your nice bag. You're giving FiO2 of 100%. There's a different type of mask called a Venturi. This is a Venturi mask. How do I know? Because Venturis are quite colorful as the name, okay? Or sometimes they are quite clear, all right? But look for the Venturi barrel where you have your gauges of oxygen. 24% FiO2, 48% FiO2, and there's always a port for them to exchange air with. You want to use a Venturi mask as opposed to a full-blown non-rebreather mask because a patient has COPD or they have a smoker's lung or restrictive lung disease. Such patients are dependent on CO2, okay, to breathe, to trigger their breathing. So now if you flood them with 100% of oxygen, you're going to reduce the trigger to breathe. Okay, so here you go. There's a Venturi, and this guy here has a Venturi. Okay, but your non-rebreather mask is initiated quickly. You want to also be careful. If your patient is already unconscious, you want to start with a high-level oxygen and then monitor them. Okay, so this is usually the first case because some people will say, my patient already came in unconscious. I could not ask him whether he has any fibrotic lung disease, restrictive disease, or any COPD. What am I supposed to do? Start with a non-rebreather. 100% of oxygen with a non-rebreather mask at 15 liters per minute. Then you can titrate, okay? You need to know the difference between a Venturi mask and a nebulizer. Where's my nebulizer? Here. They look almost the same because they have the ports, the exhalation ports where you exchange air. But the nebulizer has a nice compartment where you can put whatever your salbutamol or your ipratropium in it. Okay, so just watch for that. So you're not putting a nebulizer on a patient who needs a Venturi. Has it happened? Absolutely. That's why I have these pictures here. Give you more information. As we conclude, I want to talk to you about airway adjuncts. The nasopharyngeal tube and the oral pharyngeal tube. We have this in our clinical lab with, and I'm having doctors practice how to put in an oral pharyngeal and a nasal pharyngeal. They are not hard to use. Okay, you just need to know how to measure them. So this is a nasopharyngeal. Nasal, it will go and end in the pharynx. Okay, big thing, you want to get your gloves on. You want to measure from the tip of the nares to the tip of the ear or the tragus. So there are two different ways. Tip of the nails to the tip of the tragus. There are very many sizes. So you may have to pick a couple and just measure them. Yeah. You lube up the side and you just go in. Then after this is in, you want to put on a mask with a bag mask and now ventilate them. 1 Mississippi, 2 Mississippi, 3 Mississippi. Check for those oxygen levels, they're coming up. I need to get a definitive airway. So can you please get me an anesthetist so that we can put an endotracheal tube, okay? Or if you're proficient in inserting ET tubes, then you can just have the nurse give me, get me the emergency trolley. Then you can put in an ET tube using your Mac or your Miller. Okay, but for the level of the FY2, we have to know about airway adjuncts. The oral pharyngeal tube, what if they have, you know, this is a traumatic incident and half of their face is gone? You won't be able to put in a nasopharyngeal in case it goes in through the nose and ends up inside their pituitary gland, okay? With injury, you never want to use this. With injury to the face, you never want to use either one of them. Your next mode of intubation would either be through a crike, okay? Underneath there are dams up. Okay, no, we sing tomorrow. It's Sunday, yeah? Or you may try and do a trick, but a trick is in a controlled situation. It's never an emergency. A crike always first. Yeah. How do we measure for this oral pharyngeal? It is from the tip of the middle of the incisor. Okay, the middle of the incisor to the tragus or to the tip here. That is your distance. You measure it, you put it in like a spoon, and then you flip it over as it goes down, as it goes into the patient's mouth. Nothing challenging, but you have to know how to manage airway as an FY2. Yeah. Then you bag mask and you continue. So COVID emergency patient, is it anything different from any other respiratory emergency? No, really not. You just have to make sure that your eye is on that monitor and do not move from airway until it is fully managed. Okay. Good. Now, I think we're going to have to just change a few things a little bit. We will do our mocks tomorrow. So maybe I can do like an hour of mocks. We'll do a few cases in the beginning. I want to talk to you about naughty colleagues. You know, cases, so I hope you're here tomorrow. Cases that are quite strange, yeah. One of the worst breaking bad news that we had to do was to give a woman information that the CTG of her pregnancy came back, you know, the child was not responsive, the ultrasound is not showing any heartbeats, so it's a stillbirth. Okay, I think that's the worst case we have ever had to do in the NHS of a breaking bad news, and I want to take you there tomorrow. Yeah, because if you know how to break bad news to a woman who is expecting a pregnancy, for the last 10 years, this is her first baby and the baby is dead, you know, it's going to be quite a challenge. If you can manage to do that, then I think any other case that is brought to you in any clinical exam will be fine, okay? So we'll talk about that. I want to also talk about abuse in the hospital. So let's say you are the FY2 in the geriatric ward and you see Samantha Jones pushing a patient into the bathroom. What are you going to do? What are you going to tell her? Who are you going to report to? Okay, so I've chosen a couple of good cases for us to manage tomorrow, but at least we're done now with this section. Tomorrow we'll do a little bit of those cases and then I'll give you a nice good hour for our mocks. We'll probably do 4 of them. Dr. Dominic, I know if you're there, you've been patiently waiting. I hope we are able to see you tomorrow. And then Dr. Busola is still up on the chopping board for her mock. And then any other person who will be able to answer the questions, yeah? So this concludes our day 4. I will see you tomorrow. And let me pen off and then I'll answer your questions.